So, General Robb, one of the ways that your agency is changing the way the military healthcare delivers health and care is by implementing a shared services model. And I'd like to understand, what do you mean by that? What is meant by that? Why did you adopt such an approach? And could you outline some of the benefits of going in this direction?
Absolutely. Now, when we stood up the Defense Health Agency on 1 October 2013, we started out along what I call 10 shared services lines of effort. And these were the ones that we chose that were thought by our task force that created the Defense Health Agency, and then in our proposals to the Deputy Secretary of Defense on our way ahead is, where is there opportunity that the services were more alike than different. Sure. And so when you think about it, you say you have this enterprise called the military healthcare system, but we were running essentially, not totally independent, but we were running three separate parallel healthcare systems that were supported by, again, a single budget plan and single policy, but the execution was kind of left up to the services. So as a result, you had three separate health information and technology systems running out there. Some are compatible with the others, some not. You're running three separate contracting outfits. You're absolutely running three separate medical education and training platforms, and in many ways, although it was migrating, three separate research and development entities. So it made sense that we bring those folks together and look at ways to be more efficient and more effective. In other words, get rid of redundancy, get rid of duplication, and adopt what we call a joint first mantra. And so, and as we found in 12 years of conflict, when you're sitting out there at, whether you're at the Bagrams, the Balads, the Kandahars, or the Ibn Sinas, when you're working side by side with your Army and Navy and Air Force and Marine colleagues, but even also our coalition force colleagues, you find out, you're not so different after all, and why do we have potentially three different kind of anesthesia machines, or why are we taught three different ways to do this? And I saw the joint trauma system really bring us together. That was one of the really good, what I call game changers in this conflict, where we agreed on common clinical practice guidelines and algorithms, and that's why we were able to, again, I know in my heart why we're able to drive this particular conflict down into the lowest, again, died of wounds and lowest lethality rate in the history of recorded conflict. But it was the coming together and deciding what works, and join first. And so that's where we're going. Of our 10 shared services that we stood up on 1 October, 8 of those are already what we call IOC, or initial operating capability, and the next 2 will be at IOC by the end of the summer. And then we are fully expecting on 1 October 2015 to be fully operational capable across the full spectrum, to where we are providing that service, that core service, back to the services. And I want to say it again, this is important. The same men and women, the same dedicated professionals that were doing, health information and the technology, or they were doing logistics inside their service, are the same folks that are now doing that inside the Defense Health Agency, except they're working side by side, with an Army, a Navy, and an Air Force colleague. And it makes sense that what you're going to see is you're going to see the strengths of each one of those services, making the entity even stronger.
Yeah, so I'd like to actually explore each one a little bit about these shared services. And the first one you mentioned, which was the TRICARE Health Plan. Your charge, one of your charges, is to rein in the rising cost of health care.
Right.
And I'd like to understand better what's going on in this shared service. What are you doing with the next generation of contracts that you can let us know about? And what are some of the key initiatives underway? Absolutely.
Well, again, as we are a microcosm of the macrocosm of the nation. And, again, the healthcare and healthcare cost debate is not unique to the military. And it affects our nation, and so I think this is going to be a learning experience for both of us as we go down this journey.
Sure.
For us in the military, the healthcare costs some of the factors that have contributed to our rising costs are several factors. One is the increasing number of benefits. Number two, the increasing number of beneficiaries that are allowed to use our system. The increased use by our beneficiaries of our healthcare plan. And then number four, one that we don't have as much control over, and that is, of course, healthcare inflation.
Sure.
And although currently right now it's kind of flatlined, but I don't think there's anybody out there that says it's going to stay there very long. So we need to really again get after this. The defense health budget, or the military healthcare system, is about 10% of the top line of our Department of Defense budget. So you can see that one, we feel that we have an obligation to provide the most effective and the most efficient health care that we can, again, at the same time maintaining, again, high quality health care. And so in our, as you can imagine, our line components are saying, can you help us out here, and
sure.
so that's when you think about it, again, what's driven the creation of the Defense Health Agency, and again the strategic vision of our Deputy Secretary of Defense, and of course our Undersecretary for Health Affairs, that this entity called the Defense Health Agency will help contribute to that. Because if you executing those dollars in the delivery of that health care in the most effective and efficient way you can, and maintaining a high quality output is key. Is key. And so one of the major areas is our healthcare plan. Just in the last year, we've done a lot of things that have made a difference. And again, these millions add up.
Yes, they
do. The implementation of the Seoul Community Hospital reimbursement. We've got $6 million out of that. What we call our outpatient prospective payment. We've got another $700 million out of that. Management and administrative actions. Some of the efficiencies that we've gained just with internal organization is $2 million there. When you talk about standardization, we run three, as you know, managed care support contracts, North, South, and then West. But what we had three separate TRICARE regional operator directors. Well, what we now is we've consolidated that down to what we call one, so that even though there's three separate contracts, but we're working off the same sheet of music. So if somebody's doing something better out west, then by God, we're going to bring that up, and then we're going to and then sort it out, do the business case analysis, business process reengineering, and say, hey, can we do this in the east? Can we do this in the south? And so just little simple things like that, where we think as an enterprise. We think joint solution first are really, really making a difference. Now, when we look at the next generation of what we call TRICARE Health Plan program, we are in the process of what I will call information gathering.
Sure.
And so we've had several skull sessions, several strategic offsites where we talking to, again, our current customers, talking to our current folks in the military, but more importantly, we've had several blue ribbon panels where we've brought leaders in the industry from the civilian sector out there that are recognized, delivering high quality healthcare plans out there. Come talk to us about, what has been their experiences in their journey to, again, a more effective and efficient and a high-quality organization. And to a T, all of them say the same thing, is that the undermining pin of whatever you decide to do, but you need to be a continuous learning organization, and you've got to be able to, again, continue to watch the data and monitor the data and then analyze it and then deliver it and then continuously feed that back. And so, we've learned a lot from these folks. And so the way we do our healthcare contracts now and the way we do it 5 years from now may be a lot different based on the input we get from not only from industry, but there's a lot of smart people thinking about there's a better way to do business out there.